My name is Sang-min Park, and I am from Seoul National University Bundang Hospital in Korea. Today, I will present a multi-center randomized trial that compares E. coli-derived rhBMP-2 with hydroxyapatite against autologous iliac bone graft for interbody fusion in TLIF. This study was supported by research funding from CG Bio. I have no other conflicts of interest to disclose. Autologous iliac bone graft has been the gold standard for spinal fusion for decades. It is the only graft material that provides all three biological properties required for bone healing at the same time. However, harvesting AEG comes with a real cost. 1 in 4 patients experiences donor site morbidity. Systematic reviews report chronic harvest site pain in 3 to 14% of patients. Beyond pain, AEG also carries the risk of nerve injury, hematoma, and iliac fracture, and it provides only limited bone volume in multi-level or revision surgery. rhBMP-2 is the most biologically active substitute, but CHO-derived rhBMP-2 has 2 structural problems in TLIF. The first is regulatory. The FDA approved CHO-rhBMP-2 only for ALIF, and the KFDA approved E. coli rhBMP-2 only for posterolateral fusion. Both are off-label in TLIF, and this trial is intended to support expanding the indication to TLIF. The second is that classical BMP complications are reported in 8 to 17% of TLIF cases: radiculitis, seroma, ectopic bone, osteolysis, and subsidence. The third problem is cost. CHO-derived rhBMP-2 costs several $1,000s per kit, and a recent review put its incremental cost above most accepted thresholds at $136,000 per qual. For low and middle income systems, this price is largely out of reach. The need is clear: a safer and globally affordable rhBMP-2 for posterior approaches. The two rhBMP-2 products differ in a few key ways. CHO uses mammalian cells and is glycosylated. E. coli uses bacterial fermentation and is not. In vitro, CHO is slightly more potent, but the critical point is that in vivo efficacy is equivalent at matched dose, and E. coli production takes weeks rather than months. The carrier, not just the molecule, drives the release profile. CHO rhBMP-2 is delivered on an absorbable collagen sponge, which releases about 78% of the loaded dose in the first 24 days. This is a burst-release E. coli. rhBMP-2 is delivered on a hydroxyapatite ceramic granule, which releases only 22% over the same period. This is sustained release. The per-kit cost of the E. coli product is also substantially lower, which widens global access. First, the sustained release carrier. The collagen sponge curve crosses the inflammation threshold, while the hydroxyapatite curve stays below it. Second, the low dose, roughly 1/7 of historical CHO-TLIF series. Together, these keep the local rhBMP-2 concentration below the threshold that drives radiculitis, seroma, and ectopic bone. This is the rationale our trial set out to test. Novosis, made by CG Bio in Korea, combines E. coli rhBMP-2 with the HA carrier. The prior clinical evidence is encouraging. In posterolateral fusion, CHO reported 100% fusion at 24 weeks in their 2017 randomized trial, with superior bone quality compared with AIBG. Their 36-month follow-up in 2023 confirmed durable fusion. In a single-arm TLIF study, Quan reported 100% fusion at 52 weeks, with no radiculitis, no seroma, and no anti-BMP antibodies. These results are promising, but every one of these studies was either single-arm or in a different surgical setting. There has been no head-to-head RCT against AIBG in TLIF until now. This brings us to our pre-specified hypothesis. We hypothesize that E. coli rhBMP-2 with HA is non-inferior to AIBG for interbody fusion in TLIF. This is the largest RCT of E. coli rhBMP-2 in TLIF published to date. We randomized 154 patients in a 1-to-1 ratio. The study was conducted at 6 Korean tertiary academic centers. Recruitment ran for 36 months, from February 2022 to February 2025. The primary endpoint was CT-based segmental fusion at 52 weeks. The design was prospective, multi-center, randomized, assessor-blinded. The first patient was enrolled in February 2022. Recruitment reached its midpoint in August 2023. The last patient was enrolled in February 2025, and the last 52-week CT, which was the primary endpoint cutoff, was completed in February 2026. We performed standard open TLIF at all 6 centers. This was not minimally invasive surgery, and it was not endoscopic. The only difference between the two arms is the graft material packed into the PEEK cage. In the rhBMP-2 arm, we used Novosis at 0.5 to 1 mg per segment, with a maximum of 2 mg per patient. In the AIBG arm, we harvested 8 to 10 cc of cancellous bone from the posterior iliac crest through a separate incision. The operation was the same, the hardware was the same, and the local autograft was the same. Only the interbody graft differed. In this trial, we used 0.5 to 1 mg per fusion segment. The landmark 2K8CF study by Crandall in 2013 used an average of 7.3 mg per disc, which is about 7 times more. Combined with the sustained release kinetics of the HA carrier, this low-dose protocol is the key reason that we did not see the dose-dependent BMP complications reported in CHOEA absolute CRAST as D. First, we used CT only, with bony bridging assessed on 1 mm slices. We did not use plain radiographs, which overcall fusion by 10 to 20%. Second, we scored each level separately. We did not use a patient-level summary that smooths over a non-fused level. Third, our readers were blinded. 2 independent spine surgeons evaluated the scans with allocation masked, and the inter-rater agreement was a 0.85. And fourth, we counted only Bridwell grade 1 or a 2 as fused. Many studies count grade 3 as probable fusion, but we did not. Kwan 2024 was a single-arm study with XR confirmation and reported 100% fusion. Crandall 2013 was an open-label study with a 7.3 mg dose and reported 99%. Kwan 2018 was a retrospective registry and reported 93%. Under our strict definition, you should expect a fusion rate in 92%. 154 patients were randomized and 150 received the assigned graft. 121 completed the 52-week CT, 61 in the rhBMP-2 HA arm, and 60 in the AIBG arm. The loss to follow-up was 21.4%, within the published range for spine RCTs, and sensitivity analyses confirmed robustness. Baseline characteristics were well balanced between the two arms. Mean age was 67 years in both arms. 57% of patients were female, and mean BMI was 25. Roughly 3/4 of patients underwent single-level fusion, and the baseline ODI was around 47. At 52 weeks, the segmental fusion rate was 83.3% in the rhBMP-2 sub-OHA arm, which is 65 of 78 segments. In the AIBG arm, it was 79.0%, which is 60 of 76 segments. The between-group difference was plus 4.4%, favoring rhBMP-2 sub-OHA. The critical value here is the lower bound, which is minus 8.0%. This lower bound exceeds our pre-specified non-inferiority margin of minus 10%. Therefore, the non-inferiority of E.coli rhBMP-2 derived H2A22 AIBG is confirmed. This conclusion is robust across every sensitivity analysis we pre-specified. The per-protocol analysis, which was our primary, gave plus 4.4%. The full analysis set gave plus 3.9%. Worst-case imputation, where all missing values are scored as failures, gave plus 6.0%. Best-case imputation gave plus 3.0%. The two subgroup point estimates were plus 4.5% for single-level fusion and plus 4.2% for two-level fusion. In every analysis, the lower CI bound stayed above minus 10%, and the NI margin was never crossed. Fusion quality also favored rhBMP-2 tozo. Definite fusion, grade I, was 60% versus 55%, and total fused segments, grade I plus TO, were 83% versus 79%. The two blinded readers agreed almost perfectly, with a Cohen's kappa of 0.85. From here, I will show you representative cases. I will show only one AIBG case, and the rest will all be AFGMP2. And I will show only the cases treated with the 0.5 mg dose. The 1 mg dose tends to achieve union more easily, so I chose the 0.5 mg cases on purpose, because that is the dose most of you would doubt. This first patient is a 56-year-old woman with spondylolytic spondylolisthesis at L4-5, who received 0.5 mg of rhBMP-2 with HA. The postoperative CT shows complete fusion with none of the complications, no radiculitis, no seroma, no subsidence, no ectopal bone formation, and no osteolysis. This is a patient who was treated with autologous iliac bone graft at the same surgical level as case 1. The 52-week CT shows Bridwell grade 2 union and symptoms improved. There were no notable complications in this case either. This is a 65-year-old woman with degenerative spondylolisthesis at L3-4 who received 0.5 milligrams of rhBMP-2 1-Ha. The CT shows union with no complications, except for about 2 millimeters of subsidence. This is a 54-year-old woman with spondylolisthesis at L4-5 who received 0.5 milligrams of rhBMP-2 HA. The CT shows grade 2 union with no other complications, except for about 3 millimeters of subsidence. This is a 61-year-old woman with spondylolytic spondylolisthesis at L5-1 who received 0.5 milligrams of rhBMP-2 Seoul. The CT shows grade 1 union with no complications. Notably, the complete union is seen on the left side outside the cage rather than within the cage. This is a 60-year-old woman with central canal stenosis at L4-5 who received a 0.5 milligrams of rhBMP-2 Doveri HA. She recovered well with no complications, and the fusion was judged to be Bridwell grade 2. This is a 76-year-old woman with central stenosis at L4-5 who received 0.5 milligrams of rhBMP-2 derived. This was a non-union case with about 2 millimeters of subsidence and no other complications. Even so, the clinical symptoms still improved. This is a 72-year-old woman with spondylolisthesis at L4-5 who received 0.5 milligrams of rhBMP-2 HHA. This was a non-union case accompanied by about 5 millimeters of subsidence with no other complications. Even so, the symptoms still improved and no revision surgery was required. This is a 65-year-old woman with spondylolisthesis at L4-5 who received 0.5 milligrams of rhBMP-2 Ditober. The immediate post-operative CT showed that some of the grafted bone material had migrated into the canal. On the 52-week CT, part of it had resorbed, but some remained, confirming ectopic bone formation within the canal. Importantly, there was no radiculitis or radiculopathy. There was about 2 millimeters of subsidence, but the segment achieved complete union. These are an ecta bone formation case and an osteolysis case. Case 10, like Case 9, still achieved grade 1 union with no radiculitis or radiculopathy. Case 11 was classified as non-union with osteolysis, and there were no other complications. Patient-reported outcomes improved significantly in both arms. ODI, VAS, and EQ5D all improved, and every outcome exceeded the MCID at each time point. There were no significant differences between the two arms. In short, equivalent symptom relief and equivalent quality of life. For the 3 classical rhBMP-2 complications, we observed 0 out of 76 in every category: 0 radiculitis, 0 seroma, and 0 anti-BMP-2 antibody. Cage subsidence was 19 versus 13%, which is not significant, and no revisions were required. Serious adverse events were 5.3 versus 1.4%. Cerebral aneurysm, aspiration pneumonia, and intestinal necrosis, all adjudicated as unrelated to treatment. The only donor site event was 1 wound dehiscence in the AIBG arm. Ectopic bone formation was seen in 4 versus 2 patients, and osteolysis in 2 versus 1. Neither difference was significant. A few points are worth making. These were radiographic findings, and they appeared in both arms, not just the rhBMP-2 arm. Some of the osteolysis cases were classified as non-union, but the symptoms still improved, so no revision was required, and no patient developed anti-BMP-2 antibody. Taken together, the sustained release carrier may have somewhat reduced the classical complications such as radiculitis, ectopic bone formation, and osteolysis. There are 3 things this trial changes. First, surgeons can consider skipping the iliac crest in 1 and 2 level TLIF. The fusion rate is equivalent. The ODI, EQ5D, and VAS scores are equivalent. And there is no donor site harvest. Second, low-dose E. coli rhBMP-2 with hydroxyapatite keeps the classical complications absent. We observed 0 radiculitis, 0 seroma, and 0 anti-BMP2 antibody. Third, this approach is globally feasible. The per-kit cost is approximately 50% lower than that of CHO-derived rhBMP-2. The product carries KFDA approval for posterolateral fusion, and use in TLIF remains off-label pending further regulatory data. In summary, equivalent fusion, no donor site morbidity, roughly 7 times lower BMP dose, and about half the cost. Thank you very much for your attention.